I'm Dr. Lance McGavin, and in this presentation I'm going to discuss the relationship between probing depths, gingival margin levels, clinical attachment levels, and clinical attachment loss. The goal of this training is to standardize our periodontal assessment and diagnosis process across our entire team. By ensuring that we all understand these measurements and how they relate to one another, we can improve consistency, make more accurate diagnoses, develop appropriate treatment recommendations, and continue delivering the exceptional level of care that White Palm Dental is known for. This presentation is intended for every member of the White Palm Dental team. Whether you are a hygienist performing the periodontal evaluation, a team member assisting with charting, or myself confirming the diagnosis and treatment plan, each of us plays an important role in this process. A clear understanding of periodontal measurements allows us to communicate effectively, work efficiently, and provide our patients with the highest standard of care. Throughout this presentation, we'll review how to accurately measure and interpret periodontal findings, how those findings correlate with radiographic bone levels, and how to use the complete clinical picture, including inflammation, bleeding, calculus, and other risk factors to determine the most appropriate treatment recommendations. I'm confident that by the end of this presentation, any questions or uncertainties surrounding periodontal charting and evaluation will be clarified, and we'll all be operating from the same understanding and expectations moving forward. So let's get started. A few learning objectives. By the end of this lesson, you'll be able to define probing depths, define what gingival margin levels are, clinical attachment level, and the difference between that and clinical attachment loss. You'll be able to explain the relationship between these measurements and correctly interpret what positive gingival margin values are and accurately chart periodontal findings and curve. You'll be able to correlate periodontal charting findings with radiographic bone levels to make sure that what you're doing in curve is accurate with what you're seeing on the patient. You'll be able to make a good decision on whether the patient needs a regular prophy, a gingivitis cleaning, or a scaling and root planing. You'll be able to use inflammation, bleeding, calculus, systemic disease, and other findings to support diagnosis and treatment recommendations. A little bit of background from me. During dental school, I was very privileged to train under Dr. David O'Connell, a periodontist, for 4 years. And he was not only a professor of mine, he was a personal mentor of mine, and he is actually one of the smartest individuals in the periodontics field. He served as the president of the AAP in 2023, and he has spent decades in private practice and in academia teaching how to properly diagnose periodontal disease. This photo here is of me giving him my stole of gratitude at graduation, because he was such a great mentor to me. We spent many hours talking about periodontics, going through many questions and going through many of the scenarios and types of discussions I'm going to be having with you in this presentation today. He is very intelligent, and so I just say this to confirm with you that what I am teaching you today comes from a credible source. He taught me right, and he was able to give me the skills necessary to have a proper understanding of periodontics. One of the things that he stressed is that periodontal diagnosis is not about collecting numbers. It's about understanding what those numbers mean in the context of the disease. So I'm sure you've been told this before, but when we're charting, periocharting, we do not need to be exactly accurate. It's impossible with our human eyes to be able to get the exact measurements down to the very millimeter. However, we are striving for consistency within ourselves. So when we do a measurement at one appointment, it should be similar the way we are measuring at the next appointment. We should have consistency in the way we measure things. We are shooting for precision. Precision is not accuracy. Precision means that we are getting close to accurate, and we are consistently getting close to accurate without being exact. Reproducibility, I discussed this already. but we want you to be able to reproduce the same measurements time after time after time on a similar patient so that we can have a comparison between two situations and it's reproducible. Defensibility. If we were to ever go before a lawyer with the legal system, we could defend our findings, we could defend our measurements. And then finally, clinical usefulness, that we're using all of these measurements to actually apply it and use it to make a diagnosis. Without accurate interpretation, these following things cannot be determined: disease presence, true attachment loss, and disease progression. We need a proper diagnosis or we cannot determine the appropriate treatment. We cannot just go off of blanket rules around probing. We need a full diagnosis and a full picture in order to do that. Proper reimbursement is important. The documentation must support the treatment we are providing. Inconsistent charting can lead to insurance claim denials. And fortunately, because we have maintained a high standard in our office, we have had 0 scaling and root planing claims denied by insurance. And I want to keep it that way. Audit risk. If we were to ever be audited, we could show that we are doing what is right. We are not over-treating or under-treating. And then, of course, lost reimbursement. If we are underdiagnosing our scaling and root planings, of course, we're not going to get paid for the services we provide. If we are over-treating, then obviously we are doing a disservice to the patient. We are stealing their money. Patient trust, they lose confidence if the measurements are inconsistent. If they come at one appointment and they're told you're just a regular prophy, 6 months later they're told, hey, you have severe periodontal disease. That breaks a lot of confidence with the patient and makes them question what we're doing as a team at White Palm Dental. They lose confidence when the findings contradict another hygienist that they've seen, and we see that regularly when they come from another office. The only thing we can do is stay consistent within our office, which is part of the purpose of this presentation, is so that we can be consistent within our office. When we consistently chart, it builds a lot of trust with the patient. And if we can show them that they have a certain disease process, 95% of patients will agree with that as long as we can show them the evidence. And finally, legal documentation. The periodontal charting is an integral part of the permanent record of the patient, and it must be defensible if we were ever to face a court of law. Again, in regards to precision and consistency, absolute accuracy would mean we are measuring the exact accurate amount of a probing depth, for example. It is down to the millimeter. We get it right every time. That is not as important as precision, which is as close as we can get, and we are consistent, meaning we are doing the same thing every time. We are getting very close every time. And so we want to have consistent probing force, consistent angulation, consistent recording habits, consistent interpretation. I understand, we all understand when we're working with millimeters that a small variation is expected. However, it's the trends that are really important. We need to have the proper relative differences. If we're looking at 2 different papilla right next to each other and we're saying that one is at a certain level and we can visibly see that the other one is about 1 millimeter shorter, we need to make sure that that relative difference is charted. It's important that we standardize within our office. No 2 providers are going to be exactly the same, but as long as we are trying to get as precise as possible, get as close as possible to the proper probing depths, that's what's going to be important. And as long as we standardize and we are staying consistent and we are all on the same page as far as diagnosis and findings, that's what's important. So I'd like to define each of the definitions of these different measurements first, because I think this is important. If you don't know the definitions and you don't fully understand them, it's really hard to make these assessments, to make these diagnoses, and to have the proper measurements. So probing depth, we're going to go over this first. Probing depth is simply put is the distance from the gingival margin to the base of the pocket. So if this is the gingival margin, the edge of the gingival margin, we're placing our probe down in here, and wherever that probe ends, that is the probing depth. In other words, the probing depth is the height of this pocket. It could be 3 millimeters, it could be 10 millimeters. However long this pocket goes down, we need to make sure we're using proper probing force so we get an accurate reading. That is the probing depth. Ideally, we would like people to have a 2 to 3 millimeter probing depth. Why is that? Well, 2 to 3 millimeters is the ideal situation to be able to keep your gums healthy. If you have 2 to 3 millimeters, you can brush, you can use a Sonicare toothbrush, an electronic toothbrush. It will get a lot of that out, and then when we go in with the floss, it'll get the rest of that out. When we have more than 2 to 3 millimeters, it makes it harder. We don't have the tools at home to be able to reach down there into that pocket and get all that flushed out. So a greater than a 4 millimeter probing depth could be a possible sign of disease. It could be just a pseudo pocket or an overgrowth of gum tissue. It also could be normal depending on the person and depending on the anatomy in that area of the mouth. A greater than 6 millimeter probing depth is usually disease, but there may be other factors not attributable to disease. Some of these factors may include the presence of extra bone in the back of the mouth, distal to the second molars, forcing the gum tissue up, forcing the patient to have a 6 millimeter probing depth, even though it's not an indication of disease. Gingival margin level. This is the position of the gingival margin relative to the CEJ. In other words, where is the tip of this gum tissue in relation to the CEJ? It could be above the CEJ, which would be considered gingival overgrowth, which in many scenarios is healthy to have your gingival margin level above the CEJ. And so in this scenario, if the CEJ is right here, this gingival margin is above the CEJ. It could be equal with the CEJ. If the gingival margin started right here, it would be equal. It could be below the CEJ, and it could be down here. If this is the CEJ, it could be clear down here, and if that was the case, then we would be seeing root surface. And if we're seeing root surface, that means the patient has had recession. Clinical attachment level. Now this is the hard one for many people to understand. The clinical attachment level is the distance from the CEJ to the base of the pocket. It tells you exactly where the gum tissue actually physically attaches to the tooth. It's exactly how it sounds. Where does it clinically attach to the tooth? What is the level? This level is relative to the CEJ. And so if this level is here, it is below the CEJ. Ideally, if we could move this attachment up onto the CEJ right where that point is, that is what we would want. See how this is a large pocket? This is too deep of a pocket for this patient to keep clean. In a healthy scenario, this gum tissue would come across here and pin right here onto the CEJ. And so this value, clinical attachment level, is the most important value for determining presence of disease. We cannot determine presence of disease with probing depth alone or gingival margins alone. We need to figure out what this value is. And in order to figure out this value, we need to calculate the probing depth and the gingival margin levels to then determine what the clinical attachment level is. Now, clinical attachment loss. This is confusing because you could shorten both of these into an acronym of CAL, and now you're confused because it's the same, clinical attachment level, clinical attachment loss, but these are two different values. The acronym CAL represents clinical attachment level. That is not the same acronym for clinical attachment loss. I have not seen an acronym for clinical attachment loss. We just say that the entire thing. We can say CAL for clinical attachment level. Clinical attachment loss is something a little bit different. Clinical attachment loss represents the actual loss of the gum tissue attachment from where it started. Everyone's attachment starts in a slightly different spot. Most people, so when this apically migrates, so in this case, there's been some loss because ideally this gum tissue started here right at the CEJ, and now it has migrated down, which means there has been clinical attachment loss. If it never migrated down and it was still attached here, the clinical attachment level would be at the CEJ, but there would be no attachment loss, presumably. Now, it's impossible to know what the clinical attachment, original clinical attachment level is on a patient without asking God, but we can assume a couple of things. In a healthy, normal patient, their clinical attachment level either started at the CEJ, right here at this dot, or 1 millimeter below it. So if we have someone whose clinical attachment level is 1 millimeter below the CEJ, we are not going to assume that they've had a clinical attachment loss necessarily. We're going to assume, well, there's a good chance they started there, so they have not had any loss of attachment because they started 1 millimeter below this dot. I hope that makes sense. Now, if they've had 4 millimeters below this CEJ, we're going to assume they've either had 4 millimeters of loss because potentially they started right here at the CEJ, or we're going to assume maybe they had 3 millimeters of loss because maybe their gums started right here 1 millimeter below the CEJ. So this is a little bit tricky of a concept, but clinical attachment loss must take into account that everyone's clinical attachment level, where it started at when they were a young adult, it has to be taken into account because that level then determines the starting threshold for where their clinical attachment loss then occurs. So it's really important to understand how all of these measurements work together to then come to a diagnosis. This is very confusing, and I understand it's confusing. It isn't taught well in hygiene school, unfortunately. And truthfully, many dental schools don't teach it well either. If the dental school does not have a rock star like Dr. David O'Connell, who I learned under, there to teach these principles and there to enforce these principles with the students, then they're not going to learn it correctly. I've known many dentists, many wonderful dentists who I've had these discussions with, and it goes way over their head. I've talked to many hygienists who don't understand this principle. It's not their fault. They were not taught these things in school. Why weren't they taught these things? Well, their professors, the people who were teaching them, were never taught these things. So my goal is to teach all of you so that you can be at the forefront of this knowledge and of the proper treatment and measurement protocols so that we can get everything correct and do it correctly for our patients. Most people are simply taught in hygiene or dental school that a probing depth greater than 4 millimeters means SRP. However, there is a lot, and I mean a lot more to it than this. Hence why I'm doing this presentation. I want you to think of the tooth as on an XY axis with the CEJ, the 0 point. Now, what is the CEJ? The CEJ is the cemento-enamel junction. Where the cementum meets the enamel, there's a little faint line, a faint ledge almost, where you can see the edge of the enamel then turning into the cementum that's now covering the root surface. I want you to think of it as an axis because it's going to help us visualize these numbers better. If we look at everything going down the root, these we're going to conceptualize as a negative value. -1, -2, -3. Everything going above or coronal to the CEJ, which is where this x-axis line is going to be a positive value. +1, 2, 3, 4. The CEJ is our reference point. Coronal is positive, apical is negative. So what are things that go in the negative direction when we're taking measurements for perio charting? Well, the most obvious and important that we do on a daily basis is probing depth. The probing depth is going negatively down this axis, right? Okay, recession as well. When we can see part of that root exposed, we are measuring this value below the CEJ. So that is a negative value. Clinical attachment level. How far down this root is that gum tissue actually attached to the root? Where does it snap onto the root? Where is that point down that root? It's almost always going to be a negative value. Bone loss. Bone loss is going to be somewhere down here on the root. Bone loss is not going to be up here on the tooth. It's not going to be a positive value. It wouldn't be bone loss if it was a positive value. So when we have bone loss, it's down here on the root. Positive direction. What do we have that goes in the positive direction? Well, really there's only one thing, and that's gingival overgrowth, or the papilla filling in this space up here above onto the tooth. This is a positive value. +1, +2, +3, +4, +5, and so on. If you think of the tooth on an axis, this is going to make all of this so much more simple, and I'll explain why. So above the CEJ, again, gingival overgrowth or papilla filling in those embrasure spaces. Those are positive direction above the x-axis. Below the CEJ, negative values, probing depth, recession, clinical attachment level, bone loss, all of these things occur below the CEJ and go in the negative direction below the x-axis. Now this is confusing, and this is part of the reason I want to do this as well, is to help us understand how to interpret all of these things in curve, because the negative values are recorded without a minus sign in curve, but they behave as a negative value conceptually. So when we have gum tissue that goes above the CEJ and fills in that embrasure in curve, we actually chart that with like a +2 or a +3. We actually put the positive sign in there. When we're charting anything below the CEJ, we don't put a negative sign in there. We don't see a negative sign in curve. But I want you to think of it this way, that there is an invisible negative sign in front of that number, because by doing that, it's going to help you conceptualize what these numbers mean. So it's going to just show a number like 5, in this case, a probing depth of 5 millimeters. In curve, it's just going to say the number 5. But in your mind, I want you to think this is actually -5, because it's negative direction going down that x-axis or down that y-axis underneath the x-axis, and in -5 millimeters. A recession of 2 millimeters. I want you to think it's actually a -2. Clinical attachment level of 7 millimeters. I want you to think it's actually -7. If you think of it this way, you're going to be able to draw where on that axis, where that point is down the root. It just simplifies the interpretation. And I promise you, even though you don't see that number in curve, it's invisible It is there because the only way that curve can calculate these numbers is to factor in that this is actually a negative value. Clinical attachment level should also be thought of as a negative number because it exists apical to the CEJ in almost all disease states. We record it as a number without a negative sign in curve, but it is helpful likewise to visualize it as a negative. So a clinical attachment level of 8 millimeters, you can think of it as a -8. It's -8 millimeters down that axis. Or, in other words, it's 8 millimeters, that gum tissue, the base of that pocket attaches 8 millimeters down that root onto the root surface. So calculating the clinical attachment level, this is where it gets tricky because, again, curve shows one thing even though the signs, the negative and positive signs aren't necessarily there. It's showing it's calculating it correctly in curve, but it's not showing it to our eyes. So we need to know conceptually what is going on behind the scenes so that we can calculate it and know how this process works. So clinical attachment level is equal to probing depth. So if we get a probing depth of 2, in order to do this math problem, we need to add that invisible negative sign in front of our number. So if we get a probing depth of 2, we're going to add a negative. So it's going to be -2 plus the gingival margin level. So if the gingival margin level is a positive value, we're going to add it. So -2 plus 2 is going to be 0. Clinical attachment level is 0. And if we remember, CEJ is equal to 0. That is the middle of our axis. And that's what we want. In an ideal healthy scenario, we want there to be maybe a negative or a probing depth of a 2 or a 3, which we can conceptualize as a -2 or a -3. And then we add in the gingival margin, which should be a +2 or a +3. And so they cancel each other out to make it 0. In a case of recession, we need to take our probing depth of, say, 2 millimeters and a recession of, say, 2 millimeters. So we can see 2 millimeters of root surface, and then from there we get a 2 millimeter probing depth. So we add a negative sign in front of this, and we know that a recession is also a negative value, so we're going to negative and negative. -2 minus 2 is going to equal 4, meaning our clinical attachment level is 4 millimeters below the CEJ. And that makes sense. If we have a recession of 2 millimeters, we can see 2 millimeters of root before the gums even start. And then from the edge of the gums, we now have another 2 millimeters to the base of that pocket. We can take those two values, 2 and 2, and we can say there's 4 millimeters below that CEJ is where that gum tissue attaches. That's where we get our clinical attachment level. Now, if you remember from earlier on, our clinical attachment level in this scenario might be 4 millimeters. That doesn't mean we've had 4 millimeters of loss, because if they started 1 millimeter below that CEJ, we might actually only have 3 millimeters of loss. And it is possible there are patients who maybe started 2 millimeters below the CEJ, and so maybe they've only had 2 millimeters of loss. That value is less important. It really doesn't matter where they started in the grand scheme of things, because there's no way for us to go back in time and figure out where they started. It just helps us to understand the difference between all of these values. A couple of examples. If we have a probing depth of 6 and a gingival margin of +4, meaning the gums come up 4 millimeters above the CEJ, and the probing depth goes down 6 millimeters into that pocket. Then we're going to put our invisible negative sign in front of the 6. We're going to add the 4. we're going to get a 2. -6 plus 4 is going to be 2 millimeters, or our clinical attachment level is going to be at 2. Now, however, it's actually the clinical attachment level, like I said earlier, is also a negative number. So there's an invisible negative sign here. So we're getting a -2 millimeters, or in other words, the clinical attachment level is 2 millimeters below the CEJ. So we can either say the clinical attachment level is at 2, which is, if we were talking to Dr. O'Connor or a periodontist, they would know exactly what you mean. They would know that your level is 2 millimeters below the CEJ. Or we can conceptualize it and think, well, it's actually 2 millimeters below. It's a -2 in a sense. And if we're trying to explain it to someone in words, we're going to say the clinical attachment level is 2 millimeters below the CEJ. Now, if the person started with a clinical attachment level of 1 millimeter below the CEJ, or a -1, then they have really only lost 1 millimeter, because they went from starting at 1 millimeter and they progressed to 2 millimeters below, which is the difference of 1. Same thing over here. We're going to do another scenario. We're going to say that the probing depth was 6, the recession was 2. So the clinical attachment level calculation, we're going to put our invisible negative sign here. And since we had recession, we know that has an invisible negative sign. -6 minus 2 equals 8. So think to yourself, -8 millimeters on that axis. Or in other words, the clinical attachment level is 8 millimeters below the CEJ. If the person started with a clinical attachment level of 1 millimeters, or at the -1 mark, then they would have had a loss of 7 millimeters. Now we can see in this scenario, it's determining the clinical attachment loss is much less important in this scenario, because whether they have 7 millimeters of loss, or 8 millimeters of loss, or 6 millimeters of loss, in all those scenarios, they've had a significant amount of loss. In this scenario, it's a little bit more important, because we're going to have the measurements are a little bit tighter. It's the difference of saying they've got 2 millimeters of loss or 1 millimeter of loss, and that's going to be a lot harder to prove to the insurance if they're wanting to look at x-rays and different things like that. And so it guides our treatment a little bit more when we have tighter measurements like this. But when it's an obvious case like this, not as big of a deal. Okay, so why does it matter? Well, it prevents us from memorizing rules blindly, such as anything over a 4 millimeter probing depth is an SRP. It helps us to misinterpret the relationships if we're just always looking at one thing or the other and not understanding how they interact with each other. The gingival margins, recession. I see a lot of people, a lot of hygienists in this day and age, they'll just chart recession. They don't understand why they're charting the recession necessarily, and how it interacts with making these diagnoses. So it's important to understand the relationships, and then it allows us to not over rely on just the probing depth, to say, well, we have a high probing depth, so it must be an SRP. With all of these understandings, I encourage you to watch this again and again until you get it, and watch these definitions. But it allows you to visualize the anatomy of what's happening as you're making these measurements, as you probe someone, and then as you measure their gingival margins, you can visualize what's happening on that tooth. You can visualize where that attachment level is actually hooking onto the tooth, so you can know how deep down you're having to go, how much of that you're cleaning is root surface, so you can know how to be more gentle and to not over instrument a certain area, because you know that you're on root surface. All of these things are very important to our treatment. So a couple things, or one thing to point out is that two patients can have identical probing depths, but have completely different disease states. I'd like to show you two examples of this. So not every 6 millimeter pocket is SRP, for example. Probing depth alone does not define the disease. It does not tell us if there's bone level losses, if there's a loss of attachment level. It doesn't tell us the severity of inflammation, the etiology of the disease. It doesn't tell us the presence of calculus, anything like that. All a probing depth tells us is the probing depth. And if that's all we're working with, we can't make a full diagnosis. Here's why. Example 1, there's a 6 millimeter pocket. So we have a probing depth of 6 millimeters here, but our gingival margin level is a +5, means it goes up 5 millimeters above the CEJ. So if we calculate our clinical attachment level, we're going to put our invisible negative sign in, -6 + 5. That puts us at a -1. So if we remember, most people's clinical attachment level starts at a 1 millimeter or a -1. And so this person, they have had no bone loss. We'll see that on the x-rays as well. There's no bone loss on the x-rays. There's no bone loss according to the clinical attachment level, because if you haven't had any attachment loss here, you're likely not going to have bone loss. However, in this scenario, they do have heavy inflammation, so that they have all these 6 millimeter probing depths. They've got puffy gums. They've got plaque everywhere. They're a mouth breather. And so in this scenario, they'd be a gingivitis cleaning, because they have all this puffy, inflamed gum tissue in the absence of bone loss and in the absence of clinical attachment loss. Their clinical attachment level is right where it's supposed to be, but those gums are really red and puffy and swollen. And so we're just doing a gingivitis cleaning in this scenario. Now in this second example, we have a probing depth of 6 millimeters still, but our gingival margin level is actually +1. So it barely peaks above that cemento-enamel junction. So we're going to do our math equation, put our invisible negative sign in. -6 + 1 gives us a 5 millimeter clinical attachment level. Or in other words, that the clinical attachment level is 5 millimeters below the CEJ on this tooth. So what we're gonna see on the x-rays is bone loss present. With this clinical attachment level, we've definitely got root surface we need to clean, because all that 5 millimeters of root surface that we're cleaning, there's going to likely be calculus present, heavy inflammation. This is a classic case of periodontitis needing a scaling and root planing. And depending on how many teeth have this going on, determines what code exactly we use. Now, on the contrary, not every 2 millimeter pocket is going to be a healthy circumstance. So if we have a 2 millimeter probing depth with 5 millimeters of recession present, let's do our math equation. The clinical attachment level, let's put our invisible negative sign, -2, invisible negative sign, -5, -2 minus 5 equals -7. So what we're going to see in this scenario, we're going to see bone loss present on the x-rays. We're going to see there's going to be a lot of root surface visible in this scenario, because there's going to be all that exposed root surface, about 7 millimeters worth, or about 5 millimeters worth, sorry, of exposed root surface. And if they've got heavy calculus, heavy bleeding, this is going to be a scaling and root planing case. So if we assume this person's clinical attachment level started at 1 millimeter, then there's been around 6 millimeters of attachment loss. This means there's 6 millimeters of exposed root surface in conjunction with the heavy calculus and bleeding. It's a definite SRP case. despite the shallow probing depth. So if we go off our blanket rules that the only way you get an SRP is with 4 millimeter probing depths, we're going to miss cases like this. Because in a case like this is a classic case of SRP. We're going to be scaling and root planing. We're going to be planing that visible root, the 5 to 6 millimeters of visible root surface that has calculus all over it. If we're just charging for a prophy, we're doing the patient a disservice and we're doing ourselves a disservice. So an accurate diagnosis requires all of these things: the clinical attachment loss, the bleeding, calculus, bone loss, lifestyle factors such as smoking. Smoking increases people's periodontal disease chances immensely. Systemic factors, diabetes, same thing with smoking, diabetes. If you have diabetes, there's a good chance you're going to have some level of periodontitis going on. And so when you're seeing other factors that are indicating periodontitis and you see they have diabetes, we need to, our alarms need to be going off in our head, telling us this is likely an SRP case. And then, of course, clinical inflammation. We see lots of bleeding, lots of inflamed erythematous, edematous gum tissue. All of these things need to be taken into consideration to make a proper diagnosis. We cannot just blindly make a diagnosis off of probing depths. So how to chart the findings in curve? Well, probing depths, it's easy. All you have to do is type the numbers. Now remember, these numbers theoretically represent a negative value. However, in curve, you just type the numbers. So the probing depth is 2, you're going to do 2. Curve is making it easy for you because they know that you don't want to have to type in a negative every time. It's hiding in there. It's hiding in the coding somewhere. On the back end, the computer software engineers, they factored this in, but all you have to do is type in the value. So if a value without a negative or a positive in front of it in perio charting in curve is actually representing a negative value. It's just not showing the negative sign. I hope that makes sense. If it doesn't, rewind 15 or 20 seconds and listen to me say it again. For gingival margin, what I want you to do to make this reproducible for everyone, you're going to click over here on the side, you're going to click this little keypad button. It's going to pop this little keypad out. And so if you're the person charting, what we're going to do is we're going to toggle this little positive sign on. It's going to show a positive, negative. You're going to click it, and then it's going to just show positive in red. So to chart anything above the CEJ, so if the hygienist says +2, +3, or +1, +2, +1, you're going to just keep this toggled on. It's going to stay on for you, and you're just going to go, they're saying it +1, +2, +1. You're going to go plus, you're just going to hit 1, 2, 1 because it's already toggled into the positive position. So it's already going to add those positive values on this line. You're going to keep this open the entire time you're doing your gingival margin levels, because if the hygienist switches and says that there's some recession somewhere, you do not need to close this keypad. You leave it open, you leave it on the plus. But instead of physically clicking these numbers with the mouse like you would for a positive value, you're going to take your finger onto the actual keyboard and you're going to type the number, that the recession that the hygienist yelled out. So if she says 2, instead of saying +2, she's going to say 2. You're going to reach down and type the number 2 on the actual keyboard, not using your mouse. So again, it's a quick review. You're going to open this keypad, toggle the plus on for all positive values the hygienist reads, +2, +2, +2, boom, 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 +4, boom. You're going to stay in this region, and there should be a lot of positive values. But when the hygienist switches and says 1, 1, 1, you're going to leave this here. You're going to take your finger off the mouse. You're going to put your finger on the keyboard and type that number, and just that number. So a few common areas. You got to make sure you're probing, you're on the right line when you're in curve and you're marking what you're marking in curve. If you're on the probing depth line and you're charting gingival margins, that's going to screw the software up. And vice versa, you need to make sure that you're marking the probing depths on the probing depth line and the gingival margins on the gingival margin line. Putting in the wrong sign. So the only positive values we should be punching into curve are for gum tissue values above the CEJ when we're doing this gingival margin. And then, of course, assuming that probing depth equals the diagnosis. So I want everyone to use a repeatable order, and it's always important to review the radiographs before you start charting. Why is that? You're going to see where there's some radiographic bone level defects. You're going to see vertical defects, and it's going to help guide you as you're charting in those areas, as you're probing and as you're measuring gingival margins. You're going to tell yourself, okay, there looked like there was a large defect between number 2 and 3. Why am I only getting a 2 millimeter probing depth? Maybe I need to re-angulate my probe. It's going to really help you stay accurate and precise, and it's going to help you identify areas that you might miss. So always chart the probing depth. You go through the whole probing depth, and maybe halfway through, so once you're done with the top arch, you can glance back at all those areas that you just probed, and you're going to look for anywhere where a little dot of blood is oozing out of. If you see a dot of blood, you're going to tell the person that's charting for you to mark bleeding at that site. You're going to say bleeding on. Let's start on the buccal. We're going to do 3 mesial, 5 distal, 7 mesial, 10 distal, 10 facial. You're going to mark all those bleeding sites, but it's good to just do it after you've done a whole arch or half of the full arch, like the buccals of the upper. Then you stop, do the bleeding depth or bleeding points. Then you go on to the linguals. Then you do the bleeding points for that. And so we want to mark those because we want to be able to see what kind of inflammation is going on. Then we're going to do gingival margins. We're going to switch down to that second row and start over. Now, gingival margins, what we can tell the patient, they're going to be unhappy with us and all grumpy and upset that we just did their probing depths, and we're going to say, oh, we've got one more round of measurements we got to do. And they're going to say, are you kidding me? Kill me now. But what I want you to tell them is just say, don't worry, I'm not going to do any more poking. Gingival margin measurements, we should not have to poke. This is a visual evaluation. We might stick the probe next to the tooth to make a measurement, but we're not actually poking anything down in. If you're poking someone on a gingival margin measurement, then you're doing it wrong. It's literally just a visual assessment. And then furcation involvements last. And then mobility, anything like that if it's present. So again, using the mouse and the on-screen keyboard for positive gingival margin levels and using just the keyboard for recession values. We're going to use a papilla estimation shortcuts that I'm going to show you on my next slide, and always review the radiographs first. So this is going to be your bread and butter for gingival margin estimations. People have a hard time understanding how much overgrowth because they're like, I can't peel that gum tissue back to see where the CEJ is in relation to this gingival margin. How do I know what it is if I can't peel that back and see it? Well, I want you to use these general rules. If you see someone with a complete fill of their embrasure, so that gum tissue fully fills in that black triangle that they've got next to their tooth, go with a +3. If it's partially filled, you see a little bit of black space just below that where the contact point is, but it mostly fills in that embrasure, go with a +2. If that papilla is there, but it's kind of blunted and you can stick a Proxibrush through there pretty easily, +1. If they've got complete fill of the embrasure, it fully fills it in, and that gum tissue is still kind of poking up even above that point, and it's really puffy and red and inflamed, go with a +4. And then If you've got gum tissue that comes all the way up to the occlusal surface, like on the distal of a second molar, go with a +5 or a +6. Use your best judgment. Again, it's all relative. So what you want to do is you're doing these gingival margins. You want to look at it relative to the neighboring tooth. If you mark a +3 on one papilla because it fills in that most of that embrasure space, you go on to the next tooth, that next tooth, in order to mark it a +3, should also be at the same level. So you can look at them in relation to each other. However, if it looks like the tooth next to it, that papilla actually sits a little bit lower than this one, then you're going to want to make it a +2 so that it shows the relative difference. And curve then will start mapping it out as a line, and it will follow that relative difference, and it will kind of go across and then down and then back up as you make these relative differences. If you can see that CEJ and it's equal with the gingiva, then you're going to mark it as a 0. If you can see a millimeter of root surface, you're going to just mark the value as a 1. If you can see 2 millimeters of root surface, mark it as a 2. But the vast majority of patients, even SRP patients, are going to have lots of positive values because that gum tissue is going to poke up above that CEJ, and we need to know how to mark it. And if you look at it in relation to that embrasure, how much of the embrasure gets filled in, if it fully is filled in, +3. If it's blunted, +1. Partial fill, +2. It makes it really easy. You visually look at it, you can glance, you may not even need to use your probe because you're going to look and go boom, boom, boom. This is +3, +2, +3, +3, +2, +3, +1, 0. You might have to pull out your probe occasionally when you're looking at recession. If someone has a lot of recession, and you're like, wow, this has 6 millimeters of recession. But for the overgrowth, it's mostly just a visual appearance with your eyeballs. Okay, so I'm going to walk through a couple of cases in curve. In this first case, we're looking at 2 to 3 millimeter probing depths, and this is a healthy patient. So a 2 to 3, in a healthy situation, we're going to have a 2 to 3 millimeter probing depth. But once we get to the gingival margin in that same site, we're going to then have +2 to +3 millimeters of gingival overgrowth. So what will happen is it'll cancel each other out. If we have a 2 millimeter probing depth and a +2 gingival margin, then we're going to put our invisible negative sign of a probing depth +2 of a gingival margin is going to give us a 0 clinical attachment level. So this is ideally if we have an 18-year-old kid come in, they've got healthy gums, not really any inflammation. Ideally, what we should be seeing is this scenario where we've got 2 to 3 everywhere and 2 to 3 of gingival margin overgrowth to give us 0s everywhere. No attachment loss, no bone loss on the x-rays, and less than 30% of inflammation. So what we can have is up to 30% of inflammation throughout the mouth. We've got a few bleeding points, a little bit of plaque in some places. The anterior mandibular teeth on the lingual bleed a little bit as you're probing. That's okay. They're still a healthy patient. There's a range of healthy. I'm going to show you this person. This is actually me. And so I'm going to show you what these probing depths look like. Okay, so here we've got a 3 millimeter probing depth on the distal of 2. 3, 2, 3. Now, when the hygienist came back through and did gingival margins, guess what happened? +3. 0, okay? 0. Let's see how that corresponds on the chart. We've got this orange line jumps up. So if you were to actually look in my mouth, you would see I've got some recession there in this area that's leading to this this kind of jump in the clinical attachment level. And then another +3. So my clinical attachment level here is 0, 0. In the middle here, it attaches 2 millimeters below. Look what happens here on number 3. I've got a 3 millimeter probing depth on the distal, but then I've got +3, which brings my attachment level. You can actually see a little tiny point here to correspond with that is at 0. 0 corresponds with the CEJ. But in the middle, I had 3 millimeters of recession and then another 2 millimeter probing depth on top of that. So the gum tissue actually comes up here and attaches up here. The pocket still comes up decently high. I don't have a deep probing depth, but the two of them combined show me where I've had some attachment loss. And we see that across this whole side. My whole right side, I've got recession. Now, just as a point of discussion, when we are determining periodontal disease, the 2017 AAP indications for diagnosing or classifications for diagnosing periodontal disease, they came out with a 100-page document that goes over all of this. But what it talks about is actually looking at interdental. What does interdental mean? Well, dental, tooth, between, interdental. So we're only looking at the mesials and distals to determine, looking at the clinical attachment levels of the mesial and distal values to determine periodontal disease. Because when it's on the straight facial and the mesial and distal is pinned up nicely here in these normal positions, and we just have these like defects, this is due to something else. It's recession. It's due to maybe heavy brushing, some other habit. Maybe someone bites their nails or picks their gums or whatever. So we're not going off of these values to make a diagnosis. This is more a case of recession, because in the interdental measurements, we're getting zeros, zeros, zeros. Look at this. This is how it's supposed to be in a normal, healthy patient. 3 millimeter probing depth, +3 of gingival overgrowth to give us a 0 clinical attachment level. 0 equals the CEJ. We want that attachment level to be at the CEJ. Now look at this. 3 probing depth on number 8 with a +2, putting the attachment level at 1. That corresponds here as we come across the root surface. It's actually a millimeter down onto the root. Now, as I mentioned earlier, that does not mean this person, me, has had attachment loss there. We won't know unless we ask God, but I suspect it's very possible that my attachment level started at 1. And so now that it's at 1 in this area, we can assume that that's still healthy for this area. I hope this makes sense. Now on the lingual here, we've got, it looks like we've got a 4 probing depth on 4 distal, but we've only got a +2 of gingival margin. So my clinical attachment level is 2. So you could say that maybe if my attachment level started at 1, I've actually lost a millimeter of attachment there. Okay, which is not a big area for concern. When we're looking at a patient, we see a couple spots like that. We're not like, oh shoot, this patient needs SRP, this patient needs grafting and all this stuff. It's a finding. We maybe keep an eye on that area, make sure it doesn't get worse. But if we're not seeing it generally throughout the mouth or on multiple teeth, we're not seeing a pattern, not a big deal, okay? So this is a healthy scenario. Now, gingivitis scenario. We're getting a 5 to 6 millimeter probing depth with gingival margins of +4 to +5. So again, let's do our math. We're going to put our invisible negative sign. Let's say -6 +5 for our gingival margin. That puts us at 1 millimeter. So if our attachment level is at 1 millimeter below the CEJ, again, as I've said multiple times, many people are born that way. This person was likely born that way. There's no evidence of attachment loss. There's no evidence of bone loss on the x-rays, but this is the key here. The inflammation in their mouth is more than 30%. They've got really red, puffy gums everywhere. They've got lots of plaque. They've got lots of bleeding in their gums on more than 30% of their teeth. So we're going to look at another scenario here. So here's a scenario where in the front here, we've got 4 millimeters, probing depths everywhere, 4, 4. I think I had seen even some 5s in some places, but when we look at these probing depths, they still match the gingival margin. We have 4 millimeter probing depths with lots of bleeding, but, and I'm going to go back to the original one. Well, that is the original one. So lots of bleeding, but no bone loss. We don't see evidence of bone loss. All these should be somewhere around 0. All these clinical attachment levels, 0, 0, 0. We can see here the gums following. And if I show you some intraoral images, we're going to see why this case has so much inflammation. So this is a typical case of someone who's got braces. Look at that. They've got all this puffy gum tissue. Remember how I said if it fills in their embrasure and some, it's probably a +4. Well, this is a +4. But if you probe down here, they're going to have a 4 millimeter. So that 4 millimeter probing coincides with the +4 of overgrowth to account for a 0 attachment level, meaning they have no bone loss. They're healthy when it comes to their bone. But look at the findings. We see lots of plaque and calculus buildup. We see they've just got gingival hyperplasia. And I believe even since we saw this person the first time, their hyperplasia has gotten worse, especially on the uppers. I think the last time we saw this person, the gums came all the way down to here. They had like a 6 millimeter probing depth. It's not because of periodontal disease. It's gingivitis. It might be even something else, altered passive eruption, that's causing this process. So what I'm going to have to do is go in and cut this gum tissue away once this person gets their braces off. But as far as our treatment is concerned, this is a gingivitis case. Why? We cannot do SRP, scaling and root planing, on a patient who has not had bone loss. No evidence of bone loss, no SRP. That's the easiest factor to consider. Look at the x-ray, look at the radiographs, and you'll see there's no bone loss. In fact, let me go back to that. No bone loss. This person's got perfect bone levels. Young kid. Look at this down here. Boom, boom, perfect. I mean, you can't get more bone than this. Look at all that bone. And so we can't say, oh, we got 6 millimeter probing depths, we're going to do an SRP. This is going to get denied by insurance. They're going to say, you guys are crazy. We're not paying for this. They don't have bone loss. Like, anyone can see that. There's no bone loss. So we need to take that into consideration. There's no bone loss here. And then to tell ourselves, but there's inflammation. There's lots of other stuff going on. So what should we do? Well, we should do a gingivitis cleaning. And then typically what we would do is follow up with another cleaning a few weeks later to get that under control. And we'll discuss that again here in a minute. So now periodontitis, 6 to 8 millimeter probing depths, gingival margin of +2. If we do our math, let's say, put our invisible negative sign in front of that, 8 millimeters. We're going to add 2 for our gingival margin, and we're going to get negative, we're going to get a 6 for our clinical attachment level. And remember, this is really a negative value. So 6 millimeters below the CEJ is where this is at. If they started at 1, they've probably lost 4 to 5 millimeters of attachment. And so on the x-rays, what we're going to see is considerable bone loss. We're going to probably see inflammation, and we're going to see calculus on this patient. So let's go see an example of this. Okay, so here we go. We can see on number 1, 3, 4, 4. As we jump to number 2, from what I see of this orange line, there should be a defect here. Probing depth 4, 3, 3. So on the mesial, we're getting also a gingival margin. We're starting with 3 millimeters of recession, and then we're getting an extra 3 millimeters of probing depth there, putting our attachment level at 6. So we're seeing this here. We come across, wow, look what's happening on number 9. We're going to see this come up. It's starting to come up. So on 9, we had a probing depth on the mesial of 6 millimeters, but the gingival margin started 3 millimeters below, which puts our attachment level at 9 millimeters. Well, how long is that root even? Like, that tooth must be falling out. So when I'm looking at this is my part of the equation. I might be looking at this from my office as you're finishing your probing, and I'm like, holy cow, I don't even need to look at the x-rays. This tooth is going to fall out. Now, I can see the hygienist already marked up here mobility of 2, which makes sense. I'm surprised it's not mobility of 3 or 4. But it makes sense this tooth is mobile because there's very little root hanging onto this. We get up here. Let's see this one. 5 or 6 millimeter probing depth, 5 millimeters of recession to give us 11 millimeter clinical attachment level. Let's look at the x-ray. Well, we can see a photo here. Here's that tooth, 5 millimeters of recession, 6 millimeters probing depth beyond that to say that the gums actually attach clear up here, 11 millimeters down from the CEJ. Okay, let's look at the front tooth. Okay, 3 millimeters of recession. See how that corresponds? 3 millimeters from here to here, the CEJ. We can see that CEJ so well in this photo. Beautiful photo. And it starts 3 millimeters apical to the CEJ. And then when we probe down into here, we're getting another 6 millimeters up, which puts our attachment level 9 millimeters below. Now let's see what the x-ray looks like. Wow, it actually corresponds really well. Look at that. We saw on that charting, came across, now boom, it comes up. Look how little root is left. So we're getting 6 millimeter probing, 3 millimeters is where the gums start to lead to a 9 millimeter attachment loss. If the attachment should be up here and it's down here now, we've lost 9 millimeters. Definite SRP case. Look at the calculus we can see. Let's see if we can see on the photos calculus. Look at that. Tons of calculus, tons of inflammation, tons of disease going on. These teeth are going to be lost at some point because they're too far gone. I mean, this is just an obvious SRP case. When we're seeing all these factors, we need to make sure that all of our measurements and everything is corresponding with what we're seeing clinically. Okay. So again, the chart must match the radiographs. We're looking for those bone levels, furcations, defect patterns. If there's a mismatch, reevaluate. So if you're looking at these x-rays and there's an obvious mismatch here, you got this big defect and your charting shows that they're a healthy, normal patient, you need to go back and double check your work. You need to say, doubt yourself before you doubt the x-rays, because look at this. It's obvious. There's obviously a large defect up in there. It's kind of hard to see on this one because it's a PA, but look at that. We can see that large defect coming up in here. And so we need to correspond what we're seeing radiographically. Look in here, there should be something definitely going on in here. Let's look back at our perio charting. Yep, boom, it goes up into here, goes up into here, up into here. So this perio chart right here is perfect. It's amazing, because what you can do is you can watch this orange line. Curve will actually map it out for you. Watch the orange line, how it goes. There's no tooth here, which is why it comes back down. But you can see it just goes boom, boom, and then it follows exactly where that attachment level is going to, and it goes back up where that defect is, and then comes over here and it goes back up where the defect is. Same thing on the linguals, same thing over here. So what you can do is you can see, you can visualize where that bone is, you can visualize where the gum tissue is, you can almost see the disease in this person's mouth just by looking at this chart. So again, does the orange line and curve generally follow the levels of the bone and the levels of the gum clinically? It's an easy answer. If you have this patient and you've got an orange line that's coming all the way across these CEJs, you don't have any bleeding points, you don't have any probing depths, like that's a red flag that something you're doing is wrong. Maybe you're putting the numbers into the system wrong. Maybe you switch the probing depth and gingival margin levels, but it should start as you're going along. It should start mapping things out exactly the way you're seeing them. So you can kind of glance over there as the person's charting for you. You can verify, yeah, this is looking good. This is looking correct. So shallow pockets, some of these are red flags. Shallow pockets with significant bone loss. If you're getting a 2 millimeter pocket, but you have tons of bone loss on the x-rays, I'd really go back and check your work, because there's probably a discrepancy there. Or you have bone loss on the x-rays with no attachment loss showing on the charting. I guess that's the same thing I reworded. And then if you have all measurements are the same all the way across, you just got straight across 1 2 1 1 2 1 2 2 1 2, and then and you're doing that on every patient, that's a red flag. Okay, and I'm gonna start holding you to that if I'm seeing that, because that's just not likely on every patient. All right, that's going to happen on some of our teenagers. We're going to see that, but in a lot of cases we're not going to see that. Or if we are seeing inconsistent patterns, we're seeing big areas where the gums are jumping up and down, we're not seeing that in the mouth, you're charting something wrong. Same thing with the variability. So how to determine treatment? Again, it all comes down to the full diagnostic picture, not just one number. So for a prophy, D1110, the mouth is healthy. There's no bone loss. There cannot be bone loss for a prophy. And there's minimal inflammation, less than 30%. Well, what does that mean? Well, it's kind of subjective. But if generally speaking, you're like, well, I mean, they've got some inflammation, but there's more healthy areas than there is inflammation, we're going to just go with the prophy. Now, if it's a patient who doesn't have any bone loss, but they've got a lot of deeper probing depths, they've got lots of bleeding everywhere, they come in, you can tell they haven't seen a dentist in 10 years, they don't ever brush their teeth, they, I don't know, they've just got tons of inflammation going on, greater than 30% of the teeth, go ahead and tell them we need to do the gingivitis cleaning. And then what we're going to do is in 6 weeks, we're going to follow up with an additional prophy. They're going to be mad. They're going to be like, well, why do I have to pay for 2 cleanings? Well, tell them, if you had a off-roading car like a Jeep and you've been out in the dirt for the last 5 years, riding around in mud, and it's been baking onto your car, and it's just gotten stuck on there so hard, and it's going to take more work to get this clean. We can't just come in and have you run through a quick car wash and get all that dirt off, right? We're going to need to do this in 2 steps. You've got gingivitis, it's completely reversible, but we got to do this in 2 steps. We're going to clean you up, let things heal up, then we're going to come back and clean you up again. Just like if you were to do with the off-roading Jeep analogy, we're going to blast it with a power sprayer, get the most of the stuff off, then we're going to have you run through the regular car wash, and then everything will resolve. As long as you go to the car wash every 6 months and clean your car, it's going to be fine. Same thing with this. We just have to sneak one extra cleaning in. It's going to be out of pocket. It might cost you 50 or 60 bucks, but it's been 6 years since you've had a cleaning. Your gums are on fire. We need to do this, and we'll get this resolved, and then we can see you every 6 months. It doesn't have to be a difficult conversation. It doesn't have to be I don't have the money for this. $50 or $60 everyone can come up with if they truly want to get their gums healthy. And then finally, scaling and root planing. There's going to be true and obvious attachment loss, bone loss visible on the x-rays. There's going to be lots of calculus, inflammation and bleeding, disease progression. There's going to probably be some systemic factors such as diabetes, environmental factors such as smoking. And then we just have to determine, are we doing a D4341, which is 4+ teeth? Are there at least 4 teeth in that quadrant involved? If so, it's just a full mouth SRP at the highest SRP rate, which is the 4341. If you're like, really, it's only just a couple molars in each quadrant, I don't think it's a full-on SRP with every single tooth involved, then what we can do is a 4342, where we're just billing out 1 to 3 teeth per quad and doing that. So just as a review, I'm going to show 3 different photos here. I really love this photo. I've seen this photo going back years now. It just pops up when I search these types of things on Google. This is one of the main photos. It illustrates things really well. All of these photos, the clinical attachment level on the tooth is at the same place on the tooth. So, but in different scenarios, it's going to be a little bit different. So here we have a clinical attachment level of 6 millimeters. All of these are going to be 6 millimeter clinical attachment levels, which means this pinkish line down here is positioned 6 millimeters below the CEJ. But we have 3 different scenarios that can get us there. We have a scenario where we have a 6 millimeter probing depth, and our gingival margin starts at 0. So if we can see our gingival margin here is at 0, and we have a 6 millimeter probing depth, meaning we're going to have a 6 millimeter clinical attachment level. Now in this case, we have a 9 millimeter probing depth, but the gingival margin is 3 millimeters above the CEJ. So that's a +3. So remember, our probing depths are a negative value. So if we take -9 and we add +3 to this, as we can see illustrated in this, we're going to get -9 + 3 is -6. So our attachment level is still at -6. And then finally, in this scenario, we have a 3 millimeter probing depth, but we also have 3 millimeters of recession. So if we take that as a negative value, -3, and we add a negative value for the recession, -3, also equals -6. So in all of these scenarios, we have the same attachment level, but depending on what that gingival margin level is doing is going to change what is going to dictate exactly what we get for a clinical attachment level. And in this case, it brings it to the same level, but in many cases it won't. And that's why it's important to know exactly how these numbers interact so that we can accurately diagnose and accurately make our measurements. So just as a summary, probing depth alone does not determine disease. Clinical attachment level is the most important measure to guide treatment. Think of the CEJ as 0 on the axis, on that vertical axis. Gingival overgrowth, we're going to think of as a positive direction and positive value on that axis. Unfortunately, in curve, it shows with a positive sign. Probing depth, recession, clinical attachment level, and bone loss are all in the negative direction conceptually on that axis that I showed you. But unfortunately, it does not show that negative sign in curves. You just have to remember, if there is a number in the charting in curve without a sign in front of it, it's theoretically a negative value. Radiographs must match clinical charting. Consistency matters more than perfect accuracy. I don't care if we were to take a piece of the gum tissue off and measure it under a microscope if it's exactly 4 millimeters, as long as you're close. But I want you to be consistent. I want you to measure the same way every time, measure properly with the proper angulation, so that we can have some consistency. Because what will happen is, when you see this patient back in 6 months, if you're not consistent measuring every single time the same way, then you're not going to be able to see if there's any improvement. But if you are consistent, you'll see the improvement. You'll see that it went from a 4 to a 3, or a 4 to a 2, or a 6 to a 4, because you were being accurate, or you're being consistent and precise with your measurements. And then finally, the treatment must be based on a full diagnostic picture, not a single measurement. So I'm going to do a final demonstration of charting and curve. Oh, I did want to show this photo actually real quick. So this is a photo of a second molar on a teenager. See how this tooth looks like it's buried in all this gum tissue. You know, if we were to measure down in here, probably, in fact, let's look at it, probably deep probing depths. Let's see. So we have on 2 a 6 millimeter probing depth, on 15 a 5 millimeter probing depth. So 6 millimeters of gum tissue here. But I guarantee that the attachment level is still at 0, because we've got 6 millimeters of overgrowth. See how it comes all the way up here. Why is this happening? Well, it likely just an anatomical reason. We don't know why. When it came in, the tooth came in, it pulled all that gum tissue with it for some reason. It didn't stay where it was supposed to. But this is all just floppy extra gum tissue. So we didn't need to do an SRP. We didn't even need to do a gingivitis cleaning, because it's healthy. It wasn't puffy and red and irritated. It was healthy. It's just anatomically still a difficult area for him to keep clean. And so what I proposed to his parents was a gingivectomy to remove this, to bring it down to the normal level. And as you'll see in the photos here, this is after the gingivectomy on, I believe, the other side. We can see now all this is exposed, and then this is that side. All this is exposed. So all I had to do was take my scalpel and cut away a collar of gum tissue here to expose this tooth. I had to do a filling too, because he had a cavity there, because he wasn't able to keep it clean. But now this is going to heal up. He's going to have all this extra space. His probing depths are going to be 2 to 3 millimeters. But this was not a case of gingivitis or periodontal disease. It was just an anatomical anomaly. Okay, so let's go to a test patient. I'm going to show you a couple things with charting in curve. I'm going to do a new exam. So again, over here on our probing depths, this is where we're going to do our 3, 2, 3. See, it's bringing our The orange line represents the clinical attachment level. If we just do probing depths, it's saying our clinical attachment level now is 3 millimeters below the CEJ, and we know that's not the case. But we have to get all the data put in before it can fully calculate everything. But just watch it as it's going, 222. If you see a defect on the x-ray, it's likely, say there's a big defect between here. Okay, yeah, it's corresponding with where we're marking this deeper probing depth. So then when we come back to do our gingival margins, in a healthy scenario, I'm going to click on my keypad over here. Remember, in a healthy scenario, I'm going to turn this positive on. I'm going to go through and say +3. Oh, we're going to come over here. +3. Look what it does. It brings that clinical attachment level back down to 0, and that it's showing that in that red box. +2, +3, +2, +3, +2, 2, 2, 2, 2. Now, if I need to mark recession, I can't show you this in the video, but I'm not going to click here. I'm using my finger on my keyboard, and I'm going to mark 2 for recession. All I had to do was click. I didn't have to unclick any of this. I just marked it. And then 3, 1, or 2, 2, 2. These are all recession. Now I'm coming back to a positive value. +1, +1, +1. So it starts to map out what we're seeing on the x-ray. Now I can close this once I'm done with all the probing and the gingival margins. I can come down here. If I want to mark mobility on a tooth, 1, 2, or 3. 1 is slightly mobile. 2 is slightly movable. 3 is like it's really moving. It's flapping in the wind. Okay, don't overcomplicate it. It's all relative. But I can mark mobilities. I can mark bleeding points. So if we're still on our probing depths, what I would do is when I get to this other side, I'm going to visually glance back at everything. And I'm going to come back here and I'm going to say, all right, 2 distal bleeding, buccal, mesial, 6, all 3 points. It's going to put a B here. And then if there's any suppuration is if there's any like pus coming out. You see yellow fluid coming out of that sulcus. You're going to mark that as well. Suppuration. Mobility, okay? Furcations, that's if you're on the buccal, it's showing you here a point, which furcation. We're looking at this furcation. If we're on the lingual, there's 2 of them. It's showing which one, the distal or the mesial furcation. Then you can mark, all right, is it a 0 furcation? Is it a 1? Does it go in further, or does it go all the way through with the grade 3? Okay, so we can mark all of these things to really give us a clear picture of what's going on. And then finally, I want to show you some tricks you can use. There's this legend down here in the corner. It says legend, click on that. It's going to show you exactly what all these things mean. So this black value is a pocket depth that's less than 4. If it's a pocket depth that's 4 and over, it's going to be a red value rectangle. Then gingival margins less than 4 is going to be in blue. Over 4 is going to be in red. Those are going to stack on top of each other. Clinical attachment level, it's going to be a point with this line connecting. And then if it's over 3, clinical attachment level is over 3, that's a bad sign, so it's going to turn it red for us. Bleeding, red. Calculus, yellow. You can actually mark calculus down here too. Plaque, suppuration, mobility, furcations. So where was the calculus? Maybe I turn that off. Anyways. And then if you click here under legend, you go to all shortcuts. It will bring another screen open. Now it used to, looks like the link is broken now. I'm sure they'll get that updated soon enough. But there was a whole other legend of keyboard shortcuts you can use, and the one I'm gonna give you that's gonna be the best shortcut to use in a case that someone comes in with severe gingivitis or severe periodontal disease and they've got bleeding everywhere, and you don't want to have to go through every single thing and hit bleeding points on every single one, and everything's bleeding. You can hit Alt, the Alt key plus B, Alt B, and it will turn all of them bleeding points, okay? And then what you could do is then you could go unmark some of them to help you out. Just another little trick to help you out. But the more accurate we can make this chart, the better. It's going to improve our success rates, improve our satisfaction from the patients, improve our documentation, improve our reimbursements, even though we've already had 100% reimbursement rate, but it's going to maintain that. You can also switch to the table view. This is the same thing, it's just in table format. You could chart this way if you wanted, but it just goes through and you can do it for each one of these. It's just a table version of that same. I like the graphical, but some people like the table, and that's okay. You can print the exam, say print without notes. It always prints it with in the table view. It doesn't ever print the graphical view, I don't think. Let's see. Yeah, so it's only going to print the table view. But if the patient wants this, what you can do is you can use your snipping tool, you can screenshot it, and then you can print it if they want to see the actual graphical view of this to get a better idea of what's going on. So anyways, I hope this was helpful. I hope that you learned a lot and that we can standardize. If you still have questions about any of this, I would encourage you to please go back, watch the section that you have questions about. I can almost guarantee you your questions will be answered if you watch it over and over again until it clicks. It will click. It's a little bit confusing the first time you hear it, but after you solidify it a few times in your mind, it will click and it will make sense, and you will be in the top 5% of hygienists as far as your knowledge of charting is concerned. And so again, I'm grateful for you and your willingness to watch this and to learn from this. If you still have questions after rewatching it, please come to me. I'm happy to sit down with you and discuss this with you in more detail. Thank you for your attention, and I hope you have a wonderful day.